కొంచెం మనసు بس ينفع؟ السلام عليكم، بسم الله الرحمن الرحيم. Good evening, everyone, and welcome to the second episode of our Neonatal Online Grand Round. This is the second episode, and as we promised, we will try our best to continue our online Grand Round monthly. And just to remind you that this Grand Round is based actually on the cases that you share with us. For those not familiar with the meaning of the Grand Round is actually a case presentation or interesting case presentation that has multi-specialty input. As today we have interesting case, and I will comment on the case later, and then Dr. Saif, our pediatric surgeon, also will have an input on the case. And as I said, we every month we wait for your interesting cases that you would like to share with us, and then we will present it in the later episodes. I have received some of your cases already in the last few weeks, and I promise that I will go through it. And if I feel that one of your cases is interesting, then I will be in touch with you, and then you will have to prepare the case, of course, with our collaboration, and then you will be presenting in our future episodes. Today, I will be the moderator of the session, and I will also present the case and the commentary on the case from the neonatal input. So let me first introduce myself to you. My name is Dr. Hisham Tawakkul. I am adjunct professor of pediatrics at Khalifa University in Abu Dhabi. I'm also the program director of the neonatal fellowship at Corniche Hospital, and I'm of course the consultant neonatologist in Corniche Hospital in Abu Dhabi. I'm American board certified pediatrician and neonatologist, and I have been practicing since year 2001. Okay, so as I said, this is our online Grand Round, episode 2. And now let's start our case. So this case was for a baby XY. The baby was born at 25 weeks. It was a male infant with a birth weight of 710 grams. And the baby was admitted, of course, to the NICU with the initial diagnosis of prematurity, respiratory distress syndrome, and rule out sepsis as routine in these cases. Just to tell you a little bit about the pregnancy history, this pregnancy was spontaneous pregnancy, and the course of the pregnancy was uneventful. The maternal labs during this pregnancy was within normal limits. There was no abnormal labs. Mother did not take also significant medication, maybe some vitamins and other medication needed during the pregnancy, and the baby or the fetus was a single. During the labor and delivery, there was a history of premature rupture of membrane more than 18 hours, and there was possible coronary amnionitis as the mother had some low-grade fever and some mild abdominal tenderness, so the diagnosis of coronary amnionitis was raised. The baby was delivered flat, was not breathing, was dusky, and was placed in plastic bag as the routine for the initial management for these babies. The initial steps of resuscitation were done. Heart rate was less than 60 beat per minute. So the baby received positive pressure ventilation, which was initiated. So the heart rate improved with PPV, and the baby became pink. Baby was then intubated at about 6 minutes of age or life, and surfactant was given at 15 minutes. After giving the surfactant, the baby was weaned from the FI. Now let's go through the NICU course. In day 1, as usual, the baby was still on invasive conventional mechanical ventilation. The baby received only 1 dose of surfactant, and then the FI2 was weaned gradually, as we mentioned, so there was no need for a second dose of surfactant. As routine for these cases, for all babies in our unit, less than 1,500 grams, we place UVC and UEC. So they were inserted just after delivery. And as the baby had respiratory distress and with diagnosis or suspicious about chorioamnitis, of course, septic screen was done and the baby was initiated on antibiotics. The first line in our unit is penicillin and gentamicin. Some other unit also might start ampicillin and gentamicin. The baby was placed in PO and was initiated on total parenteral nutrition. We usually start on the first day. Total fluid was 100 ml per kilo, and the baby was at this time was still MPO. So all the nutrition through TPN. These are the initial labs, and I will just pause for 1 or 2 minutes just for you to review the labs. So initially we did CBC and blood gas, and as I said, blood culture was done, and the baby was initiated antibiotics. The CRP was 2. And the electrolytes were done in the first day of life at 24 hours. For those you use different units for the creatinine, you should divide this creatinine by 18. So this is not really significantly high creatinine or BUN. So as you can tell that these initial labs were all within normal limits as expected for this kind of prematurity. And these labs, as I said, the CBC and the blood culture were done, and the blood gas were done just after delivery, and the electrolytes were done as routine at 24 hours. The baby had an initial X-ray to check the position of the ET tube, and of course to see the lung inflation and how the lung status is. And UVC and UEC were placed. So also to confirm the position and the tip position of the UVC and the UEC. Because the ET tube was a little deep and the UVC was high, the UVC was pulled out. Although the tube actually still deep in this second X-ray, but the UVC was pulled out, and the repeat X-ray showed that now the UVC in lower position than the initial X-ray. So these 2 X-rays were done actually in the first day to, as I said, to confirm the position of all the tubes, the ET tube, the UVC and the UEC, and also to look at the lung. The first X-ray was done on the left side, and the second X-ray was done on the right side. Just to continue the NICU course, the baby from day 1 to day 5, the baby was stable in the first 5 days of life, so there was no significant events. The baby, as I said, was on conventional mechanical ventilation, receiving on assisted control mode with volume targeted ventilation or volume guarantee, 5 ml per kilo. The blood gases was acceptable. The total fluid was 160, as we mentioned, 160 ml per kilo, and the baby was in TPN. And then in day 2 or 3, there was some trial to feed the baby. So the baby was initiated on milk, breast milk, 0.5 ml through nasogastric tube, and the baby was feeding every 3 hours. We said already that the baby had septic screen, and we started on our first line, penicillin and gentamicin. We also started caffeine and nystatin in the first day of life as our routine for the care of this preterm labor. There was some jaundice as expected for this prematurity, so the baby was initiated on single phototherapy. On day 6 of life, the baby started to have a decreased urine output. So the urine output in day 6 was down to 0.7 ml per kilo per hour. As those who are do bedside round with me, or those who are familiar with my courses, anything wrong the first question to ask is why this something is wrong. And for example, if in this case the baby presented with decreased urine output, so the first question that should we ask is what is the cause for this decreased urine output? Baby was stable for 5 days with good urine output, and all of a sudden the baby presented with decreased urine output. So in this scenario, the first question it should be asked is why the baby have decreased urine output. This question you should ask yourself about any problems, anything abnormal. The first thing that you should ask is why. If the baby presented with urine output decreased, then you should ask why the urine output is decreased. If the baby presented with hypotension, you would ask why the baby have hypotension. If the baby decreased with electrolyte imbalance, you would ask why the baby have now electrolyte imbalance, and so on. So in this case, baby presented only with decreased urine output. So we ask this question, very important question to be asked at this stage, why there is decreased urine output and the baby was stable for 5 days before. So let's ask ourselves now, and I want you to think about the differential diagnosis for this decreased urine output, and then ask also what would you like to do next after you ask this question. So I'm also again pause for a few seconds for you to give a differential diagnosis of possible differential diagnosis to explain this decreased urine output. I would like also to remind you that if you have any questions, please raise your hand and write in the comment section the questions, because at the end of the 2 sessions, we will answer your questions. Okay, so let's now share with you the differential diagnosis that we thought about that could explain the decrease in the urine output. Number 1, hypotension. It could be sepsis, renal failure, necrotizing enterocolitis, though it's early for this baby, but it's a possibility, dehydration, and increased fluid loss. If you have any differential, maybe you can add it also to this list, but this is what we came with as a differential diagnosis of possible diagnosis that can cause decreased urine output. Now, we already have the answer for the first question. Is we came up with a differential diagnosis to explain this decreased urine output, and now we need to narrow this diagnosis. Of course, we cannot tackle all these problems, all of them. We need to dig more from the history, from the examination, from the labs, from imaging, from anything you can put your hand on to gather information, and now we need to narrow this diagnosis. So let's share with you what did we do to narrow this diagnosis. So the first thing we did, that we took history. The pregnancy and the delivery history already we know, but we need to know what happened for the baby for last 5 days, and also what happened in particular in this 6 days of life prior to the incident of decreased urine output. So we took history from the nursing staff, and also we did physical examination for the baby, and we came with these findings. The vitals were more or less normal. There was no hypotension, and the heart rate at this time was 170 beat per minute. The only significant thing was there is mild abdominal distension from this morning. So not from the time of the presentation. The nursing staff mentioned that the baby since that morning had mild abdominal distension, and because of this, the feeding were discontinued in the morning. So by the time that this was actually at night of the day 6, by the time the baby presented with urine output, the baby was already placed NPO in the morning because this abdominal distension, which could be expected for this kind of prematurity at this stage. They also did abdominal X-ray in the morning. So now we ask ourselves again, so what we will do now? There is nothing really very significant in the examination, except that there is some abdominal distension. So the first thing, that because there was an X-ray done in the morning, we reviewed the X-ray. And I leave you with this X-ray also to take a look at it. This X-ray was done in the morning. And as I said, we are now at the night of day 6. This X-ray was done in the morning. The UVC is still in the place that we placed in the on the day of the admission. And the UEC here, it's a low position because they pulled it as it was pulled before, so it was dragged to low position X-ray, low position UEC, which is more or less within acceptable limit. Maybe I would like to pull it a little down more, but it's okay. It's at L2, it should be at L3. So this is the X-ray that was done on the morning of day 6. And then we repeated the labs also to narrow the diagnosis, as I said, and come with to narrow the differential that we mentioned. So we repeated the labs, and you will see here second column. So I placed here the labs which was done at birth and the labs which were done at day 6. So if you look here to the labs, again, I'm going to leave you for a few seconds just to figure out what was abnormal here in these labs. And you will find only that 2 things only were abnormal. Here, the potassium at this time was 7.5. So there was hyperkalemia, and there was also thrombocytopenia. So now we have a baby with decreased urine output, with abdominal distension from the morning, and labs only hyperkalemia and thrombocytopenia. And I will show you back the X-ray, and this is the X-ray which was done. Okay. Now, let's use this information to narrow our diagnosis. This is the diagnosis that we came up with, and let's narrow the diagnosis. Hypotension, we said the blood pressure was normal at this stage, so the hypotension was ruled out. Sepsis, it's a possibility. So, of course, sepsis can cause decreased urine output and can cause thrombocytopenia. And maybe because of the decreased urine output, the baby also presented with hyperkalemia. Renal failure, but here the renal function was not really significantly high, so the renal failure was also ruled out. Necrotizing enterocolitis, if you remember the X-rays, there was no signs of necrotizing enterocolitis at all. There was no pneumatosis or perforation, so NEC also was ruled out. Dehydration, that's not possible. The baby, because the baby was receiving enough fluid, so the baby was receiving around 160 ml per kilo at that time, which should be enough for the baby. Hydration. Increased fluid loss. The baby actually did not have any evidence of fluid loss because there was no polyuria. It's actually, there was oliguria, and the baby did not have any increased stools frequency, and the baby was ventilated. So the baby, all the insensible water loss or sensible even water loss also was not enough to explain this oliguria. So there was no fluid loss, more or less. So the only thing we left here with is sepsis. From our differential, we narrow this diagnosis now, and the diagnosis now was sepsis. If you have any other thoughts, you can come up with a review again. This is the X-ray. Okay, these are the labs, and I showed you what abnormal. And I said the last thing that left for us is sepsis. I'll pause for a few seconds for you to think now. What's wrong with this baby? The answer is there already. You should, by some slides that I review with you, you should have already put your finger on the diagnosis, or at least suspecting something. Okay, so after, and I'd like, just before I share the answer for you, this is the way we should practice medicine. You have a complaint, you should have a differential for this complaint. First, ask why, and then have a differential, and then dig more in the baby by examination, by labs, by investigations, by history, whatever you do. But you need to narrow this differential and come up with 1 or 2 differential, and then you proceed with them. So here, through this process, we actually ruled out most of the diagnosis we have, and we only left with sepsis. But there was something interesting in the X-ray which was done in the morning, and that unfortunately was missed in the morning. Now let's show you back the X-ray that was done in the morning, and see, this is the X-ray in the morning. And if you can see here, you will find this air, 3 bubbles of air here. Okay, See, these 3 bubbles of air was measured on the X-ray that was done that morning. So the question at night, what are these bubbles here? This is very interesting bubbles. Don't look like bowels. See, the bowels all are gathered here in the bottom of the abdomen, but these 3 bubbles here are not explained by this. You cannot say that these are bowel loops. So what are these 3 bubbles? This is the question that came now, very interesting, and that will solve the puzzle for you if you know what are these bubbles. So at this stage, we have a baby with abdominal distension from the morning. Baby was placed NPO. There is no bowel distension, as you can see, and there's no necrotizing enterocolitis, but we have 3 bubbles here. These 3 bubbles in our mind it can be one of 2 things. Either this perforation, which is unlikely because this 3 bubbles distribution like this, they don't come like perforation. Perforation usually will have air under the diaphragm here, but not like isolated bubbles like this. The second cause, or the second explanation that we came up with in these bubbles, that there is a problem with the UVC. The UVC is in a low position. It's not actually in the accurate position. It was pulled. If you remember, in the first day, the X-ray was pulled back and came to a low position. This here, the UVC is around T10, and that's lower than the normal position, or the optimal position should be in the IVC at the junction of the right atrium. So this low position UVC could have extravasation and could cause these bubbles here. So as I said, this is the X-ray that was done in the morning, and unfortunately these bubbles were missed. So to confirm this, we repeated the X-ray again at night after the complaint of the decreased urine output. And again, you can tell here that there is a bubble still here. And we also did left lateral decube to rule out that this is perforation and this gas is under the diaphragm. So again, in the left lateral decube, you cannot say that this is actually perforated air, perforated bowels, because the bubbles are still there and they're isolated from each other. So this is raise our suspicion about that this could be a complication of UVC extravasation, as the UVC now is not in an optimal position. So after we came with this diagnosis that this could be secondary to the UVC, we did some extra labs. So we did liver enzymes, and we also did coagulation. And you can tell here that the coagulation actually was deranged. Very prolonged PT was 61, and the PTT was 109, and INR was 5. So this baby was showing signs of DIC already. And the liver enzymes were very high. The AST went up from 25 on the first day to more than 2,000, and the AST went from 5 to 192. So that is actually confirming that there is something wrong in the liver, and there is increasing our suspicion about something wrong related to the UVC. The platelets is 57, as we said, and there was also hyperkalemia, which we already knew before. So at this time, the UVC was removed, and the percutaneous line was placed. PICC line was inserted. The UVC had to be removed, of course, because there was a suspicion about extravasation and internal hemorrhage that caused this DIC. Later on that night, the abdominal distension actually kept increasing because probably the baby was bleeding internally, and to the degree that it actually caused increased the ventilatory support, and the lung were not able to expand enough. Again, same night or probably next day, the baby also presented with melena, which could be a sign of DIC, as we said. So now the baby is giving you flown like a picture of internal hemorrhage, and all this increased the suspicion about UVC problems. To confirm our diagnosis and our suspicion, we did next day, we did the request for abdominal ultrasound, and sure enough, if this is the liver, and you can see here this mass in the liver, and there was fluid collection, and this fluid collection had the thick wall cavity. So the ultrasound was ultrasound liver read by the radiologist as thick walled heterogeneous fluid collection within the liver parenchyma, which measures 3.4 by 4 by 5 centimeter, and it was suggestive for either hepatic abscess or liver hematoma. So it's both possibilities can be a complication of the UVC. And there was also moderate volume ascites at that time. So this was the initial findings of the ultrasound, confirming the whole picture now very clear. There is something related to the UVC, and this either can be intraparenchymal hematoma or abscess formation, and there is also moderate ascites. Now from day 7 to day 21, the baby then started to be very sick. The baby had mixed acidosis, metabolic and respiratory acidosis. The baby then had shock, hypotension, and shock that require several inotropes, and I think also hydrocortisone was added. The baby presented with anemia and thrombocytopenia that require several packed RBCs transfusion and platelets transfusion. The LFTs were stayed elevated. Baby had also coagulopathy with increased PT and PTT and required multiple FFP. I am saying multiple FFP that to the stage that we used to give FFP and platelets probably twice a day. Every day we give FFP and platelets, and baby requires several blood transfusion also. So this is increase or confirming actually that our suspicion, our diagnosis of a possible hematoma within the liver and internal hemorrhage. The CRP was repeated several times. The highest number was 18. In the first day of life, if you remember, it was 2. It went up to 18 only. And because of we were not sure at this stage or 100% that this is hematoma. We did also other investigation to rule out possible hepatic abscess. So torch was done, and herpes also were done. They were both negative. And the blood culture and urine culture that we did around the time of the presentation also were negative. So again, now, after the first 3 weeks, the diagnosis we had was either it's a liver abscess versus liver hematoma. But if you review the history and go through the course of this baby, you will favor liver hematoma as a diagnosis, liver hematoma, and of course, internal hemorrhage that explain the ascites that was seen in the ultrasound. This is probably blood. And the reason for that we favor liver hematoma because the baby presented with anemia that requires several blood transfusion. And I'm saying several, more than 5-6 times blood transfusion during the course of this 14 days, from day 6 to 21 day. So baby requires several blood transfusion. This will not be the presentation of this abscess. Why the baby will require all this blood transfusion? There was also moderate ascites, and as I said, this moderate ascites could be blood. Second, there is internal hemorrhage from the extravasation of the UVC. The CRP was low, which will not go along with hepatic abscess. CRP would maybe expected to increase more than that. And there was also negative blood culture. So these 4 things probably favor the diagnosis of the liver hematoma more than or over the liver abscess. Sure enough, after 3 weeks of combined antibiotics and antifungal, the ultrasound was repeated, and finally it showed progressive reduction in the size of the mass, which was at this stage read also by the radiologist that this was favoring this mass is actually a liver hematoma more than the diagnosis of the liver abscess. So the diagnosis for this baby was intraparenchymal liver hematoma secondary to UVC extravasation. Now let me comment on this case and just to learn some lessons from our case. And now we will talk about the umbilical venous catheters and the complication of these umbilical venous catheters. If you look to the history of the umbilical venous catheter, the umbilical venous catheter was first described in the literature. First time was used by Diamond et al. in 1947. There was a paper published in the archive, and he used the umbilical venous catheter to provide venous access for exchange transfusion in newborn babies born with erythroplastosis fetalis. If you want to review the length of the UVC, before the insertion, you should have some kind of formula or some kind of method that you will introduce the length of the UVC inside the baby, aiming to put the tip at where we said. The tip should be at the level of the diaphragm or at the junction of the AVC and the right atrium. So there are several formulas used. In our unit, we use this formula. The weight in kilogram multiplied by 3 plus 9 divided by 2 plus the length of the umbilical stump, and we put 3.5 French for the babies. This is 1.5 kilogram. For the babies who are above or equal to 1.5 kilogram, we put 5 French. This is actually one of the formula acceptable to estimate the length that you would introduce in the baby to reach the optimal position. Several studies, this is not the only formula, actually there are many formula. This study here was published in the European Journal of Medicine in 2013, and they are comparing two formulas here. The Shukla formula, which is similar to our formula, which is a revised formula, so we use the revised formula. But the Shukla formula is actually identical to our formula, but they add 1 centimeter more. So in this study, they found that no significant difference in the between the two formula to reach the optimal position. I looked also other studies that looked to estimate the length of that should be introduced in the baby, and this study here they will compare 5 formulas, not only the Shukla formula and the revised formula. There is actually other formula like the Gumella, the Shukla, the Verheij formula, and Valley and Dunn. These 5 formulas use different methods, either like some sort of calculation, like I mentioned for the Shukla formula and the revised formula. Others may use the distance between the umbilicus and the xiphisternum, and some formula like Dunn may use the distance between the shoulder and the umbilicus, and they have a nomogram to come up with a number of centimeters that would introduce in the baby. So as you can tell, there are many ways or many formulas to put estimate the length that should be introduced of the UVC. In this study, now they compare which one is the best formula to get the correct position. So this is, as you remember, F1 was Gumella and F2 was the Shukula that we mentioned before, and the last one is the Dunn. If you look to the blue color, this is the correct position, percentage of correct position. The high in red and the low in green. So the correct position, as we mentioned, at the junction of the IVC with the right atrium. The high mean it's inside the right atrium. It's the tip of the UVC. It's higher. You can see it in the right atrium, and the low, which is at T10. So they compare which formula get the most number of correct position, and according to this study, it was the Gumella, the F1, the Formula 1 Gumella is the highest percentage, which reach up to about 52% or 55% of the time. They get the correct position. But in this article, they favor the Shukla formula. The reason for this that 52% of the time they get correct position. But if you look here to the red color, more than 97% of the time, they get the position either high or correct. And that's in this study or this article, they favor this way, F2, because it is better that you get the UVC high and then easier after this to pull it than get it low and then you cannot insert it. As you know, usually we insert the UVC and then we get an X-ray and then we correct the position. So the combined high and correct for the Formula 2, which was Gomella, is more than 97%. So you will do, if you use the Shukla formula was higher because you can put it according to this formula and then you do the X-ray, and if it is deep, then you can, if it is high in the right atrium, then you can pull it. But in other formulas, if you don't leave your field still aseptic technique until you do the X-ray, you will not be able to insert it. So in this article, they favor the Shukla way. But as I said, you can use any different. The best way, actually, if you can keep your field is sterile field, even after you do the X-ray, then you can manipulate the UVC up or down as long as you can guarantee the sterility of your field after doing the X-ray. If you cannot guarantee this, then looks like the Shukla way might be the favor way, or the Shukla formula might be the best one according to this article. And just to remind you, this is the Shukla formula on the top of the slide. Again, if you would look, if you want to confirm the optimal position of the UVC, of course, you will get an X-ray, and the optimal position, as we said, should be considered at or just above the diaphragm, and it should be in the inferior vena cava or at the right atrial junction. That should be between T8 and T10. T8 and T9. T10 considered already low UVC and has this increased the risk of extravasation, as our baby. If you remember the X-ray, that the UVC was probably at T10. So the optimal position should be between T8 and T9. They found in this study also that 2/3 of the patient with a UVC tip position at T10, when they looked by ultrasound, they found that it's in the liver. So that's why T10 is not actually a good position for the UVC. And in the same study, they reported that up to 20 to 37% of the UVC placed, actually they're misplaced. They are not in the correct position, whether it's high mean it's inside the right atrium, or low mean at T10. Okay, so what is the course of the UVC and where should be the position? So we put the UVC in the umbilical vein, as we say, as we see here in the slide, and it should pass these portal veins. It should pass from the ductus venosus, which is around somewhere here, okay? And then it should pass the left portal and the right portal veins, and then it should go through the ductus venosus until it reaches the IVC, and you will introduce a little bit to be in the IVC until it reaches the level of the right atrium. So this should be the course of the UVC. Again, to share with you the course of the UVC, and this is from the Sick Kids manual. We put it from the umbilical vein. The UVC should be go from the umbilical vein. It should go through the ductus venosus, okay? If the ductus venosus is closed, and it actually closed shortly maybe after birth. It's ductus venosus is not like the ductus arteriosus, not surrounded by muscles, but it closed after the baby will be exposed to the relative hyperoxia environment, the extrauterine environment, so it will close. If this ductus venosus closed, the UVC will not, you will not be able to pass it through the ductus venosus, and then the UVC will go to the liver, possibly toward the left portal vein. And that what happens if you leave low line UVC, which is around T10. So here should be the optimal position of the UVC. As we said, should pass the portal veins. It should go through the ductus venosus, and it goes to the IVC, and you would leave it at the junction here. If you look at the X-ray, at the level of the diaphragm, or at the junction of the UVC with inferior vena cava and the right atrium. Many centers like to confirm the diagnosis with lateral X-ray, as here suggested by the Sick Kids manual. The UVC catheter insertion, position, and monitoring should be done as, of course, routinely by anterior posterior X-ray. Many centers like to confirm the position with a lateral X-ray, and nowadays the new trend is to confirm the position with abdominal ultrasound. As I said, that many catheters that the X-ray might fool you, and you think it's in the right position. When they did ultrasound, they found actually it is low. It is in the liver. The chances of misplaced the catheter reduced if the catheter is placed under ultrasound guidance. So many centers now, after the availability of the ultrasound in many neonatal units, now they'd like to use ultrasound during the initial placement, and also to monitoring the position. And mean every few days they will have a look to confirm that the UVC did not slip. And as we know, the way we fix the UVC, it's actually we tie it in the umbilical stump, but it's not actually, the suture don't go through the UVC, which means that UVC can slip out, in or out at any time. So it's better to keep monitoring the position of the UVC and make sure that the UVC did not change the position. So monitoring the UVC position is very critical, as I said, and this will be either by X-ray, and it's either EP or lateral. And I said many units already favor the lateral X-ray, and nowadays more units are using ultrasound to monitor the position of the UVC. So what are the problems or the complication of malposition UVC? If you have a low UVC in the umbilical vein, you cannot actually give administer medication, and you will avoid hyperosmolar solution in this position. If your UVC goes to the intrahepatic right or left, or even into the superior mesenteric or splenic vein, this can cause thrombosis. UVC can cause perforation for the portal vein, which can cause hemorrhage or abscess formation in the liver, as the case in our baby. The UVC slipped probably towards or close to the portal vein. If you put it too deep in the atrium, this can cause arrhythmia, perforation for the heart, and also can cause cardiac tamponade. So as you can see here, the UVC actually is, in my opinion, is not really a good line. We need it for medication and delivery of fluids, but you have to keep close observation on the position of the tip of the UVC, because if it is low, and the optimal position is very narrow. It's from 8 to 9, T8 to T9. If it is low, it can cause internal hemorrhage, and if it's high, it can perforate the heart and cause cardiac tamponade. So UVCs are very tricky lines. It need to keep good observation and monitoring for the tip of the UVC position to avoid these problems. The other complication that can be through because of the UVC is thromboembolism, of course, vasospasm, vascular injury, internal hemorrhage, infections, hepatic, renal, gastrointestinal damage if it goes to a wrong position, ascites and internal hemorrhage, cardiac complication like cardiac tamponade, like we said, and perforation of the heart wall. UVC also can rupture and can migrate. And while pulling the UVC, you can rupture, and this fragment can migrate in the umbilical artery. We actually have one case like this, which needed exploration and to get the UVC out from the umbilical vein, which was a fragment was left inside the vein. We mentioned already that the UVC tip sited at T10 or below should be only used in the short term. So sometimes you put a UVC and it did not go to the optimal position, and you try maybe to get a PIV and it's hard or difficult, or you are in emergency. So you could use this UVC, but you consider it as a peripheral line. You cannot consider the UVC as a central line and give medications and give calcium and give TPN if the UVC is not an optimal position. So and if in our unit, the routine, that if the UVC did not reach the optimal position, we try to pull it away from the liver. So we'd like to get an X-ray and we see the UVC really under the liver, because to avoid this intrahepatic hematoma and internal hemorrhage. And best, if your UVC is not in optimal position, you better remove it as soon as possible. So here in this study, they say maximum 48 to 72 hours to use a low position UVC. Here also I have a lot of articles and case reports from the internet similar to our case. If you look here in the top of the X-ray, there is a UVC placed, and there is also here the ultrasound on the left lower corner. They also presented with intraparenchymal hematoma like our baby. That's another case report. Same. See if you look here, similar to our X-ray. See, there is also bubbles here, and they did ultrasound, and very similar to our case, that this is also here fluid collection, and there is thick wall cavity, and this was intraparenchymal hematoma. So it can intraparenchymal or subcapsular hematoma. The problem in this kind of hematoma, that the babies will present with internal hemorrhage. They will all have coagulopathy, and they will have internal hemorrhage, and there is great chances of death here. In my career, I probably had 5 cases like this. And actually, the case I'm presenting may be probably the only case that we were able to save, because the diagnosis was spotted early, and the UVC was pulled early before complication. But even though that we diagnosed it early, still the baby presented with full-blown picture of coagulopathy and shock. But luckily, the baby survived. Another case here, same. See, the UVC is in the liver with a lot of bubbles around it, and see the bubbles also you can tell here in the X-ray on the right side. And this is the ultrasound. Again, you can see here a fluid collection in the liver, and there is air here also in the abdominal cavity, probably secondary to the perforation of the main vessels in the liver. So all these cases as case of liver hematoma. So timing of complication, this is from my own observation, and what's also presented or recommended in the literature, that most of the case report said that all of the patients who developed internal hemorrhage and intraparenchymal hematoma secondary to a malposition UVC, low UVC, they actually more or less they presented in the 2nd week of life, where most infants presented between days 6 and 10 after the UVC placement. And this is also my observation. Most of the cases, as I said, 5 cases in my career, they all presented probably after day 5. So the take-home message is here that the target position for UVC is at the junction of the IVC and the right atrium, which is belong to T8 to 9. Ultrasound is superior, and there is evidence to support the statement, to X-ray to confirm the tip of position of the UVC. And of course, because it's non-invasive, you can monitor the tip of the UVC every maybe few days or every day if you want. And now many neonatologists already are trained to use ultrasound, and it's easy to confirm the position using the ultrasound. Lateral X-rays, probably more accurate than AP, though it's not really a common practice in many units. We still depend on the AP, which might fool you, but some units like to confirm the placement of the position of the UVC by lateral X-ray. In low position UVC, this is very important now. The usage should be avoided unless no peripheral access is available. So, please remove your UVC as soon as possible if it is not an optimal position. As I said, the recommendation is maximum 3 days, 72 hours, and try to avoid medications. Try to avoid high calcium, because this will increase the chances of the extravasation or any hyperosmolar fluid infusion if the UVC not in the right position, and you have to treat it as a peripheral line. The maximum duration, the recommendation is as soon as possible. But if you have to, maximum 5 days. As I said, all the case reports that I read, they actually said the complications started in day 6 and later on. but better not to use a low UVC and try to replace it by percutaneous line as soon as possible. And here I thank you very much, and I hope this case is beneficial for you. The UVC is common in our neonatal unit, and it has a lot of complications, and monitoring the tip of the UVC is vital, as I said, to avoid complication. Both low UVC and high UVC, they both cause problems, and the problem is here actually they can reach mortality. And the bad thing that you will have a stable baby, like sometimes baby like maybe 28, 29 weeks, which might have a very good outcome, but the baby will die or have severe complications secondary to something I would say, an hospital error. So hopefully that we can keep our eye on our UVC and avoid such complication. And I thank you very much. And here I will introduce our next speaker. Dr. Saif al-Islam is our pediatric surgeon at Corniche Hospital. He's a consultant pediatric surgery at the Sheikh Khalifa Medical Center, and he's doing great help in our unit. And it's actually our honor to have him here tonight with us. And he will share some other information and complication about the UVC with you. And I will leave the floor for Dr. Saif. Thank you very much, Dr. Saif.
Assalamu alaikum. Good evening, all of you. I appreciate the invitation from Dr. Tawakkul to present in his webinar, and I hope this will be a useful presentation. So we're going to talk about the liver abscess and umbilical venous catheters relation. Some of these slides might be a repetition of what Dr. Tawakkul said, and just to stress the importance of these facts related to the umbilical catheter and the early diagnosis of liver abscess and liver problems related to the umbilical catheters. So just a quick introduction, which is mentioned before, and it's an umbilical venous catheter is a common life-saving procedure in the management of high-risk neonates who require neonatal intensive care unit. And it's relatively an easy procedure routinely performed in most of the NICU units. However, it is not without complication. And actually, was mentioned by Dr. Tawakkul, a lot of complication. Fortunately, they are rare, but still it's a lot of different complications that can happen if we don't look well after the catheter. if we don't keep checking the position of the catheter, and if we don't keep an eye on the baby in the unit. So complications associated with the UVC include the thromboembolism, the vasospasm, which might affect the hepatic, renal, or gastrointestinal organs, vascular injuries, hemorrhage, infection, ascites, various cardiac complications, as we heard before, including the pericardial tamponade and erosion of the atrial or the ventricular wall. And as was said as well, that it can rupture during the removal or if it was kept for a long period, and this can cause embolization or migration of fragments. If we focus on the hepatic problems, apart from the portal vein thrombosis and portal hypertension, which might happen, hepatic fluid collection, necrosis, abscess are problems that can happen and related to the IVC. On the other side, liver abscesses are very rare, but potentially fatal entity in neonates, with the majority resulting either from an ascending infection via the umbilical catheter or a portal vein, or from a systemic hematogenous spread in the course of bacteremia and sepsis, or last source is via the biliary tree. Hepatic abscess, as I said, is a rare entity. If we talk about the incidence, in 2008, there was a review and they mentioned that all the cases that they were able to identify was nothing more than 50 cases. In another review in 2020, they managed to find around what is also known to cause and be at a higher risk for liver abscess. Low position, as it was mentioned, of umbilical venous catheter appear to be an important contributing factor, and it was mentioned early that low position is the lower border of T9. So if you got T10, T11, these are considered low, and which indicate that this catheter is within the liver. And malposition on this or dislodgement. So initially you can have a good position catheter, but during the manipulation or the handling of the kits or fixation, the catheter can be pulled out, as it was shown in our case today. It is also possible that once you have this catheter and you run the TBN, that the high osmolality solution of the TBN are damaging the vessel endothelium with the subsequent rupture and extravasation. We know that the fluid in the TBN are hypertonic and alkaline in nature, and that by itself, through a chemical effect, can cause hepatic necrosis, which lead to collection, and if secondary infected, it is going to end with an abscess formation. In addition to the direct chemical effect of that fluid, also just the mere pressure and a compression of the liver parenchyma by this fluid also can add to the factor of the liver necrosis and collection formation. That's again just a quick X-ray showing the ideal position where we want the tip of the umbilical venous catheter. And this was mentioned, the different method of confirming that position. Most of the units will use the X-ray recently more and more units are talking about confirming the position at the time of insertion or after insertion using the real-time ultrasound. The agreed position, as it was mentioned, the optimal is T7 to T9, which is almost the level of the diaphragm or the level of the diaphragm with the right atrium, or which is sometimes difficult to maintain. So initially you can insert it, and then during the handling, or if it was kept for a longer periods, the this can slip or dislodge. So as mentioned by Dr. Tawakkul, you really need to keep an eye on the position and keep checking it every couple of days. The reported rate of misplaced UVC is around 40 up to 40% in most of the literature or reports. And this is associated with the extravasation of the infused fluid, can go to the liver, can go to the peritoneum, can even go to the intrathoracic cavities. As was mentioned earlier, an ultrasound-guided UVC tip location is a simple and learnable technique, and more units are adopting that techniques. The most important factors seem related to development of hepatic abscess is a low-position umbilical catheter causing parenchymal injury and damage, the hypertonicity of the infused fluid, and a longer duration of catheter placement are also contributing factors. The etiologic, if we go to the organism or bacteria blamed in the development of the liver abscess, as in all the NICU infections, earlier it was the staph, currently it's more of the gram-negative organism. Don't forget also that fungal liver abscesses can occur, especially with the prolonged exposure to antibiotic and compromised immune system, and Candida albicans is the most common fungal. In around 20% of the cases of the liver abscess, we will not be able to identify a factor, and they are called the cryptogenic abscess. If we go to the pathology of the liver abscesses, like any abscess, it's a collection of pus within the liver parenchyma. It can be located in any part of the liver, right, left lobe, anterior, posterior. However, from the reports, the majority of these abscesses are found in the posterior portion of the right lobe. The exact explanation of this problem is not clearly for us, but people think it is related to the flow of the portal vein venous blood flow. Again, the liver abscess can be single or can be multiple. And if left untreated, complication like bacteremia, sepsis, or rupture of this abscess into the peritoneal cavity can occur. Other rare complications reported, including also portal vein thrombosis. Liver abscess can also rupture into the pleural space and can result in empyema. Please remember that if this condition is untreated or treated inadequately or there was a delay in the treatment, infections, liver abscess is uniformly fatal. Clinically, if we go for a clinical picture of the liver abscess, you will find a lot of in the report that our cases following a typical presentation actually, except for the early detection. Most of the time, these cases are detected late in a course of an ongoing sepsis that is difficult to control despite prolonged use of antibiotics. There is no specific clinical finding that point toward the liver abscess with certainty, so it makes a diagnostic difficulty and dilemma. Some clinical signs that were described include non-specific signs of sepsis, like apnea, increased work of breathing, feeding intolerance, and bile aspirate, abdominal distension, what might be more specific and point toward liver etiology if the problem is a tender hepatomegaly. If labs are done, which was beautifully illustrated in our cases, an elevated infective marker with elevated liver enzymes. So it was suggested based on this that all preterm babies who have severe sepsis with an umbilical catheter in place and who do not respond reasonably well to a prolonged antibiotic course to be evaluated with a detailed ultrasound of the abdomen for a possible underlying cause of a liver abscess. So if you have sepsis, an ongoing sepsis, and you have umbilical catheter, and you cannot control that sepsis easily, consider or look for also a possibility of the liver abscess. As I said, we are lacking the specific clinical symptoms and signs, so the diagnosis is mainly radiologic. And if we do an X-ray abdomen, it may show a combination of findings. None of them is actually specific, but some of them might point toward the pathology, as it was mentioned in the case of Dr. Tawakkul. So you might see an elevated right hemidiaphragm. You might have a right side pleural effusion. And the point that was mentioned is you can get air in the abscess cavity, which may suggest the diagnosis of liver abscess. Also, it will be useful because it will show you the position of the UVC, if it is still in a proper position, or it has been displaced and become in a low position. So remember that unusual gas shadow at the area of the hepatic region, visualized on a plain abdominal radiograph, might be your tip for the diagnosis of a hepatic problem or a liver abscess, as it was illustrated. And that was one of the X-rays showing the air on the overlying the shadow of the liver and the low-lying umbilical catheter. Now, what is more specific and more sensitive and is your investigation of choice in the neonatal patient with possible liver abscess will be the ultrasound, which has a very high sensitivity and specificity, around 90%, a little bit less than CT, but there is almost no rule for CT on these small, tiny kids who are sick and critical condition in the NICUs. The ultrasound will help you in a number of points. First, it will confirm your diagnosis. At the same time, it is portable, it's readily available everywhere, and it doesn't really need any specific preparation, not like a CT where you want to give them a contrast or even sedate them. And in addition to the diagnosis, if you do a repeated or a serial number of ultrasounds of the condition, that will be your monitor for the response to the antibiotic, to the progress and resolution of the liver abscess. And it has also a therapeutic role because a real-time ultrasound can help the radiologist doing the aspiration of a solitary liver abscess. So what we will see on the ultrasound, we will see a hepatic lesion along the course of the umbilical vein or ductus venosus. These lesions can be very variable, but typically they are well-defined hypoechoic lesion with a peripheral hyperechoic rim. So the central liquefied part will be hypoechoic, blackish, while the peripheral will be hyperechoic, more toward the whitish. If you do the ultrasound late along the course of the treatment and the management, these lesions will start to involute. They will become totally hyperechoic, and some of them might show calcification. Again, these are some of the X-rays that were, the ultrasound that were shown, showing the cystic lesion on the liver, and then as it become old and mature, become hyperechoic. Another one with the X-ray, and I think that's the one that Dr. Tawakkul showed you earlier. and that's another one where the liver abscess already subsided and there is a calcification in the location of the egg. So if we come to the treatment of the liver abscess, how we will treat it, there are two main lines of treatment: the antibiotic therapy and drainage. So whether the neonatal abscess is single or multiple, or localized to the liver or diffuse, vigorous antibiotic therapy is mandatory and crucial in the management of this case. The specific selected antibiotic will depend on the causative organism and the unit where you are working, but you will need a broad spectrum antibiotic. For how long you will treat, this will depend on the number of the abscesses, the clinical response of the child, and the radiographic progress. But in general, nothing less than 3 weeks, up to 6 weeks. Some centers were treated, or some cases were treated up to 4 months. And it is recommended that the first 2 weeks of the treatment need to be with IV antibiotic. Then if you would like, and the patient has been progressing reasonably well, you can shift them to an oral antibiotic. Now, the second line of management is the drainage. And this drainage can be done either surgically or radiologically. It has evolved over time from typically open surgical technique to a more conservative image-guided percutaneous aspiration and drainage. So in a single abscess of the liver, if you detect it early and you drain it early, this actually will be the life-saving for this baby with the antibiotic. So we will keep the surgical intervention nowadays for patients with abscess that rupture into the peritoneum, or if we think that there is a biliary involvement, or if the child has been subjected to an attempt of percutaneous drainage that was incomplete or failed, or if there is other non-surgical pathology inside the abdomen. But in mind that the second most common contributing factor to liver abscess is nowadays NEC. So there is, if you will go to the abdomen anyway to deal with the necrotizing enterocolitis, these are the cases where you will deal with the abscess at the same time. Some patients are not candidate for any surgical intervention, and I think the cases that was described by Dr. Tawakkul fall into this category, where he had a very bad coagulation and severe coagulopathy. So a child with multi-system organ failure, septic shock, bad coagulopathy are not really a candidate, a suitable candidate for an open surgical intervention. Anesthesia risk, existence of, as I said, another intra-abdominal pathology, the experience of the treating physician and surgeon are all should be considered when making the best treatment decision for your child. Now, the reality that most of these lesions are often multiple and diffuse, and they are most of the time are sick. So surgical drainage is usually not doable on most of them, and they will get only medical therapy, or the other kind of interventional drainage, which is the ultrasound or image-guided drainage. So the image-guided drainage can be one of two options, either just a simple needle aspiration or a drainage where you drain and put a pigtail inside the cavity, the abscess cavity. This is the alternative to the open surgical intervention that we used to do before, and it has much better safety margin and a reduced risk compared to the open techniques, and can even be done without the need for a surgical anesthesia. Most of these neonates are in a NICU unit. They are heavily sedated. They can get morphine or midazolam, and that's for an interventional radiologist might be enough to be able to do his ultrasound guided drainage of the abscess. It has been documented from several studies that percutaneous drainage is nowadays the preferred method for drainage of liver abscesses, except in the very few cases that I mentioned earlier, when you are dealing with another intra-abdominal pathology like peritonitis, or if the interventional radiology failed to drain. Okay. Relative contraindication for percutaneous drainage still include the coagulopathy, although with the development of the local hemostats that they can inject along the aspiration tract course, they still can manage and deal with some of these cases with the coagulopathy. Other cases where interventional radiology drainage might not be suitable if they don't have an access or a window to access the abscess cavity, or if it is multiple abscesses that not communicating with each other and multiloculated, they are not the best. It is still doable, but it's not the best candidate for an interventional radiology guided drainage. This technique of drainage were introduced in 1970s in the adults and then become got adopted with the pediatric surfaces and it made a huge difference because open surgery was a high risk procedure and it was associated with a high mortality. Now these minimal interventions and invasive procedures, they have a better safety profile. And nowadays with the availability of the high resolution machines and the aspiration and drainage, most of the time can always be done safely with adequate sedation and can be done in the unit, as I said. So the decision whether the interventional radiologist will aspirate or will introduce a drain will depend on the size of the collection, his capacity to accommodate the big tail, and usually they will insert a big tail around size 5 or 6 French, as well as the viscosity of the content. If it is very liquid, he will aspirate everything. If it is significantly thick, he will consider putting a drain, irrigating with some normal saline for a few days. So summary of treatment, because most of these abscesses are small and multiple, the standard treatment will be mainly antibiotic. The number of these cases are small to have a solid protocol of treatment, and the treatment will be individualized in most of the centers based on the size of the abscess, the presence of the liquefaction and septation, the accessibility of the expertise to deal with it, and the clinical conditions of the patient. As I said, the majority of the small and multiple abscesses will be managed with antibiotic, broad spectrum for a prolonged period of time. If it is a single, you still can ask the interventional radiologist to aspirate it or put a drain. And if there is an associated abdominal pathology like peritonitis or necrotizing enterocolitis, that's when open surgery might play a role. Regardless of whatever drainage method and antibiotic treatment that you started already, these abscesses will need to be followed minimum weekly using the ultrasound. So in general, once you diagnose them early, like what happened in the mentioned case, they diagnose them early, an image-guided aspiration with antibiotic, they usually have a good long-term results. That was one of the proposed approach to deal with the neonatal biogenic liver abscesses. So child with sepsis who's not responding well to the prolonged antibiotic treatment, he will have ultrasound. The ultrasound will show if it is a solitary you can offer them a prolonged course of antibiotics 3 to 6 weeks, or you can ask the interventional radiologist to drain, and then you follow them weekly with ultrasound to assess the response and the improvement. If it is multiple from the small abscesses from the start, there's no option for drainage, and the only treatment line will be antibiotic. Outcome of this condition and prognosis. Prognosis of biogenic abscess improved dramatically. We have now better imaging and radiological investigation that help us to reach the diagnosis early. We have improvement in the microbiology identification and better and a more effective antibiotic therapy. And we have, as I said, a better drainage procedure, which is mostly the ultrasound guided drainage. The only way that we know that can help prevent the occurrence of this problem is what was mentioned earlier by Dr. Tawakkol, is to have a strict policy for a UVC catheter insertion, positioning, monitoring, whether you want 1 X-ray or 2 X-ray views, or if you will introduce and use the ultrasound. So in conclusion, as I said, solitary biogenic or biogenic liver abscess is an extremely rare clinical condition. Less than 50 cases were reported by 2008, and by 2012 it was nothing more than 150. In general, hepatic bacterial infection will have different routes to reach the liver and cause the abscess formation. Either can be ascending through our umbilical venous catheter or through the portal vein, or from a biliary duct or a hematogenous spread during a setup of a bacteremia. The causative agent of biogenic liver abscess are variable, but the majority are either staph or a gram-negative enteric bacteria. Many reports have determined that umbilical venous catheterization with a long-term parenteral nutrition use, prematurity, and necrotizing enterocolitis are the known risk factors for this condition. If you have an ongoing sepsis that is not responding as expected to your antibiotic treatment, neonatal hepatic abscess should be on your differential diagnosis. And the other point that might lead or point toward a hepatic abscess is acute onset of an abdominal distension in a neonate with an umbilical venous catheter. And I think that's resembled the case that was presented actually more than a prolonged sepsis with no improvement in treatment. If you suspected, you do an ultrasound. The ultrasound is your reliable method for diagnosis. The management of patient with liver abscess should be personalized. We don't have enough number to establish a clear protocols, but you know the basic lines of treatment. Drainage can be done both percutaneously or surgically, but percutaneous is our recommended and the first line option. These are some of my references. We are happy. Again, I would like to thank Dr. Hisham for inviting me, and we are happy, I think, to get the questions.
Assalamu alaikum. Now, as we concluded the our presentation, we shared with you a very interesting case, which is actually can be a common scenario in our neonatal unit. And we discussed with you the management of one of the two most complications related to the UVC, intraparenchymal liver hematoma, and Dr. Saif discussed with you also the management of a liver abscess. This is the two possibilities that can be raised in a similar case like that. Now we'll open the floor for some questions, and as I said, if you would like to have any questions, just type in the comment section your question and we will try to answer. I'd like to thank actually Dr. Saif for sharing his presentation with us tonight. As you can see, Dr. Saif on call, and he actually is still in his scrubs. So thank you very much for Dr. Saif for coming during your on call and give us this time. I'd like also to thank Pearl Events for their fantastic work in all our events. And we will share with you later our events that we gonna conduct in the coming few weeks under the organization of Pearl Management, Mr. Muwaffaq and Mr. Hadid. Now someone will start with questions to Dr. Saif, and then I will keep my questions for later, as Dr. Saif would like to leave because of his on-call duty. The questions for Dr. Saif, you discussed the management of the liver abscess, and you discussed that prolonged use of antibiotics and whether to evacuate the abscess either through interventional radiologist using needle aspiration or catheter or a drain, and also you discussed open surgery exploration management. The problem that we face for these babies, as you know, and as I discussed in my case, is the coagulopathy. And most of these babies actually they present with coagulopathy and DIC picture, and they require lot of FFP, and sometimes actually it is hard to control as they continue to have internal hemorrhage, secondly to the extravasation of the line in the case of hematoma. But in case of abscess, what are let's say the difficulty in the open exploration between liver hematoma and abscess? Are they carry the same risk, the same morbidity and mortality, or the liver abscess might have easier approach as might not be complicated with DIC as a case of hematoma? Which one is easier in your opinion to be surgically drained?
Ideally, if we know that the diagnosis is hematoma, that's actually a relative contraindication to go in. Hematoma is usually, as long as it's loculated and contained, it acts as a tamponade, and you don't really want to disturb that tamponade effect. Abscess, on the other side, is usually more easier to deal with because usually the localization is less and it tends to actually to penetrate and perforate on the surface. And there have been some reports of abscess opening actually on the liver abscess that open on the anterior abdominal wall. So to deal with abscess will be easier. You just need to small incision and back it. Hematoma, ideally, if you know ahead of the procedure, you shouldn't interfere or disturb an ongoing hematoma. Of course, you will need the best optimization that is possible. If you reach that stage where nothing is working, that's maybe the only time that you still might give it a trial or a chance, but that will be a very high risk procedure.
And when will be the best time to interfere surgically in the abscess? And would you try first a prolonged course of antibiotics, or you would like to evacuate the abscess once diagnosed?
Yeah, in a liver abscess, we will still would like to have a good control with antibiotic. Even if we decided that we will go for draining, we still would prefer to have a good cover of antibiotic, I'll say for a week or so before we go in. Or nowadays, better, as I said or mentioned, that we ask the interventional radiologist to drain it with a big size needle. Yeah.
Okay, one question about the needle aspiration. Would it cause another or a new abscess on its way out? And if you decide to needle aspiration, this will not introduce more infection and cause more abscesses in the liver?
I don't think so, because most of these babies are already under a good cover of antibiotic. As I said, usually the diagnosis of this problem will happen late. I mean, you keep treating the child with antibiotic and you can progress, but he is already on a good course of antibiotic. So less than needle aspiration will not spread the infection along the course of the needle or outside. Also, at the same time, the abscesses that are very superficial on the surface of the liver, most of the time they will rupture on their own, and this will be an indication for an open intervention rather than an interventional radiologist. The one that are deep, these are one packed with the liver parenchyma that will protect from the spread of the infection outside the liver.
If the baby is really still continue to have coagulopathy, it's still possible for surgical management if the baby is not responding to the in case of liver abscess, of course.
I think these are the cases that I still will prefer the interventional radiologist to put a drain in, because as I said, now the incision or the opening will be much smaller than my laparotomy incision. And at the same time, they have actually a lot of new hemostatic agent that we can infuse after we needle aspirate or after we put after we insert a drain along the course of the tract, and that will initiate a reasonable hemostasis and minimize the risk of bleeding post aspiration.
Thank you very much, Dr. Saif. And just to continue with your answers, actually many of you answer the case as sepsis during the presentation. And of course, sepsis will be on the top of the list for the differential diagnosis, but see, sometimes things will not follow the routine diagnosis or the most common diagnosis that you are used to. If you don't think out of the box and if you don't have high index of suspicion, like that case, baby was diagnosed actually in the same night, then you will miss important diagnosis like this. And as I said, 5 babies in my career, probably in the maybe the more than 20 years that I practice, and most of them died. Actually, this was the only one that was saved. Probably it was caught early. So yes, sepsis is on the top of the list, but always don't fix your mind on one diagnosis and have high index of suspicion. And what made us suspect this complication is the X-ray that was missed that morning. And somebody was asking about the X-ray. Actually, the reported X-ray did not mention anything about these 3 bubbles. It was read by radiologists, but it was not. There was no comment about the bubbles. So this was caught by the neonatologist on call, and luckily he repeated the X-ray and then suspicion about that UVC complication. Another question: how the UVC cause hematoma? As we said, the UVC, if it is in a low position, it's considered like a peripheral vein. So by infusing TPN on hyperosmolar solution, gradually the UVC will erode the wall of that vessel, and then it will cause extravasation and will cause intraparenchymal hematoma, and can cause also the internal hemorrhage in the abdominal cavity. So that is the mechanism. By infusing calcium, especially TPN, high in calcium, or medications, or any hyperosmolar solution in a peripheral vein, as any peripheral vein, the wall can be eroded, and then the vascular will be the castor will be extravasated, and then of course bleeding from that vein, because there is nothing to tamponade the vein. Surgically, also you need to know that the surgeon will avoid any opening in the liver, because there is no tamponade. After you cut the liver, there is nothing to tamponade the bleeding. So if you cut the liver, it's very hard to stop bleeding. No tamponade, and also there is coagulopathy there. So most of these babies will die. So surgeons will avoid this procedure. Regarding another question about the best management for the abscess, Dr. Saif discussed, But the best management for the hematoma, also Dr. Saif discussed, but I just want to make emphasis on it. The management of the liver hematoma, it's actually the best way is conservative management, is actually to do nothing. Not even, if you're sure that this is the diagnosis and this is hematoma, not abscess, then the best management is conservative. No needed aspiration even is required. You will do just conservative management, treat the shock, treat the coagulopathy, and most of these hematomas will regress by time, as the case in our scenario. And hopefully you will be able to treat the shock, because babies died actually not from the hematoma of the liver. They die secondary to the shock or the coagulopathy. So if luckily, if the bleeding stop, if it is erosion of the vessel is not a big tear, maybe the hematoma, the bleeding can stop, and the hematoma can be like not a big size hematoma. But as I said, these diagnoses, whether it is hematoma or abscess, carry a very high risk for mortality. Another question about the jaundice. If there was jaundice during the course of the hematoma, I mentioned already that this baby was under phototherapy. Probably this jaundice was secondary to, was multifactorial. Baby is premature, have liver injury, and there was also blood which is hemolyzed and can increase the jaundice. So probably, but I don't recall that was significant jaundice that require exchange transfusion, which will be contraindicated anyway in this case. The last question here is how UVC can cause coagulopathy. It is not the UVC per se that causes the coagulopathy, it is the consequences of extravasated UVC and internal hemorrhage. Baby will have significant internal hemorrhage, and the body here will try to seal the tear of the wall, which will cause a lot of platelets, and the bleeding itself can produce DIC. So the coagulopathy is secondary to the probably to the significant internal hemorrhage, secondary to the tear of the vessels which was torn by the UVC, and that can cause the coagulopathy. And as I said, this coagulopathy will stay for a long time. It's not like you will give, because the baby will keep oozing for number of days. You know, as we said, there is no tamponade. So the tear, the baby will keep bleeding from there, and baby will require significant blood transfusion and massive blood transfusion by itself, rather than even the internal bleeding. Massive blood transfusion causes also coagulopathy. So the baby will require multiple platelet transfusion. I think we were giving twice a day, as I mentioned, and multiple also FFP to control this coagulopathy, and this can be the leading cause of death in such cases, besides the hypotension and the shock. I don't see any other questions, so we probably will stop here. I'd like again to thank Dr. Saif for sharing this event with us, and thanks for the organizing committee, and thanks for Pearl management, and thank you all, of course, all of you for attending this event. We have probably 5,000 participants in Zoom and another 2,000 in YouTube. Just to remind you that this presentation, if you miss it or if you'd like to review it, it will be still in YouTube on the Pearl management page, and it will be also in my YouTube channel. If you are not participating in my YouTube channel, just search in YouTube by my name, and later also I will post this presentation in my YouTube channel and also on the Pearl management page. Finally, I'd like to thank you for attending our events, and I would like to share with you some of our future events. As you are aware, we are doing this again. I want to remind you, we're doing this online grand round monthly, hopefully, but we're going to depend on the presentation, good presentation that you share with us. So if you think that you have a good case in your unit that you'd like to share with us in our next event, please send me in my inbox a summary about the case, and then our committee will select the most interesting case to be presented in our coming online grand round. Now let me share with you other activities. Okay, so with Pearl management, we have multiple platforms and multiple activities we do. We have our neonatal advanced mechanical ventilation workshop. The coming workshop will be in October, and the date is now 14 and 15 October here, will be in Dubai, in the Palm Dubai Hotel. We might postpone it 1 week. You can review Pearl management page to confirm the final date. It's either going to be in that date posted here, 14 to 15, or we might actually postpone it 1 week, so you can make sure of the final date from Pearl management page. So this, as you are aware, we do this advanced mechanical ventilation probably twice a year in Abu Dhabi, and it's international course which was conducted in several countries in the Middle East. The second, we have also our multi-specialty grand round that I already shared with you, and we do have quarter annual presentation, the multi-specialty quarter annual presentation that we do probably 4 times per year, and many speakers share their presentation with us in this platform. We also have our conference, which will be in May for now. Our 7th International Neonatal Multi-Specialty Conference will be in May in Abu Dhabi, May 10, 11, and 12, inshallah, 2024. With this, I would like to conclude our night. I thank you very much for your participation. And inshallah, hopefully this presentation will add to your experience. I hope we left you with good take-home messages to save baby's life. Thank you very much for your participation, and see you inshallah in our future events. Have a good night.